Today, we're going to talk about real-time monitoring of financial risks, something that is really, really important, especially where margins are so tight in a very complex healthcare regulatory environment. So we're really happy to have you here today. And again, this is real-time monitoring of financial risks. Just to start off with some housekeeping items, my name is Dana Finnegan. I'm the Director of Market Strategy at MDaudit. Really happy to be with you today. This webinar is sponsored by MDaudit. Real quickly on MDaudit, we are a premier billing compliance and revenue integrity platform. We work with organizations across the nation, 150 clients strong, all the way up from very large academic medical centers, as well as community hospitals and really everything in between, helping them really bolster bottom lines, recognize additional reimbursements, stronger reimbursements, but also obviously billing compliantly. About today's session, just want to let you know that you are going to receive this deck after the webinar. You're going to receive the recording. Also, if you have any questions that come up during this webinar, please feel free to enter them in the chat as a question. And also want to let you know that there is going to be a survey at the end we'd like you to take just about on any other topics you may want to hear about. And one last thing I like to kind of promise through these webinars, because you're taking your time with us today, is that I can promise you're going to go home with at least a couple of nuggets that you're going to be able to infuse into your billing compliance program or your revenue integrity or revenue cycle program. Real things you could be able to monitor that you're going to get from today's presentation. We want to send you home with some actionable insights. So you'll be getting that as well. So the first place I want to start is some of the major trends we're seeing in this year in healthcare compliance and revenue integrity. And I want you to, we're going to spend a little bit of time here because these are some of the nuggets I want you to go back to and really see, is this happening in my organization? And most likely it is. So the first one up there is that volume and surgeries are coming back really strong. In the MDaudit community, we've seen a greater than 20% growth. So a lot of ASC activity, a lot of surgical volume. And this is a great thing because, as you know, surgeries are really big dollars that help bolster that bottom line when you're receiving that reimbursement. So we see surgeries going very strong. The second bullet is something that is kind of a flip-flop from last year. So last year, we saw the commercial payers really being pesky in driving reimbursement issues. This year, it's really Medicare. So last year we saw commercial, this year it's Medicare. And when I say they're driving reimbursement issues, it's almost like they're making us go backwards, like we're driving backwards. They're paying less dollars per claim, shrinking reimbursement from Medicare. They're taking a ton of time to actually adjudicate those claims. They're really hanging on to those claims for quite a long time. We'll talk about some more granular statistics with that. They're benefiting from holding on to those claims and not paying you right away. And then at the same time, in holding on to them a really long time, they're denying more claims. And again, we'll get into some more granular stats about that. So definitely want to check out your Medicare reimbursement in denial population. Another kind of scary statistic, which is our third bullet, is external payer audit volumes. So last year, we saw this really heating up in 2023. But this year, compared to last year in Q1, we're seeing an exponential increase with external payer audits. That's the folks like RACS, MACS, TPE, UPIC, and SMRC, all of that kind of alphabet soup of folks that are coming back in and looking to do clawbacks and sending you those ADRs and requests for informations. We thought this might stabilize a little bit, but we're still seeing a huge upward trend. And we're going to talk too how we're seeing a lot of this on a prepayment basis, not a post-payment basis. Another one that I'm sure all of you are aware of is the Medicare Advantage plans under incredibly heavy scrutiny for risk adjustment issues. So, I mean, anything that's being submitted with HCCs, CCs, MCCs to those Medicare Advantage plans, almost guaranteed that there's going to be an additional layer of scrutiny on those. I'm sure you've all seen that in the news. So definitely something you want to pay attention to as well. Maybe do some prospective audits on those claims going out to Medicare Advantage plans. One of the things that I think we've kind of forgotten about since COVID, it's been a while, is, and it's true, telehealth volumes have plateaued, but they still present a significant compliance risk. I go into the OIG work plan, I go into RAC Monitor and other places, and there's always still a lot of scrutiny there for telehealth volumes, making sure folks are still paying attention to how those are supposed to be billed compliantly. I think the biggest thing that we're seeing in 2023, but as well, real kind of additionally in 2024 and beyond, is that payers, government payers, commercial payers, if you didn't know it, they're all investing in AI-driven technologies. And why are they doing that? Because that allows them to receive your claims and put them through an additional level of scrutiny so they can really kind of double down on their denials. Now, we're going to talk about how you can use technology to combat that additional scrutiny by the payers, but they are becoming very, very sophisticated in how they interrogate your claims. There's no longer the days of, folks kind of stopping those claims, doing manual reviews. This is all being sent through AI, sophisticated analytics, benchmarking, and many other things that are putting you at risk, again, of higher denial volumes and in clawbacks as well. So we want to put you on similar footing than the payers, where you can be using technology to help you understand where some of your risks are. And then the last one I think we're all aware of is the major issue with the clearinghouse cyber attacks that took place in Q1 with Change. This is something that we're all aware of and really need to make sure we stay aware and vigilant with our clearinghouses and scrubbers and so on. So we went through that pretty quick, but if you add it all together and really think about it, this is creating a perfect storm of issues for you. Again, taking longer to adjudicate claims, then those claims denying, requests for information, ADRs. This is all stuff kind of showing up at your back door that are making things very difficult to again, recognize a positive bottom line. But again, we're going to get into how you can combat some of these pesky issues. The major way, the way we at MDaudit, we consider it, we're going to call it CRM for RCM. What does that mean? It's kind of a cool title, but what does it all mean? So it means continuous risk monitoring for revenue cycle management. The days of being able to just look at what's going on in your billing and remittance information on a weekly or monthly basis, it just doesn't exist anymore. You can't do that. If you're not looking at your billing and remit data and other forms of data in real time, you're going to end up getting really pinched by the payers. So let's talk about continuous risk monitoring and how it helps you deliver a healthy bottom line. So there's really three major components of this. And it may seem simple as I talk about it, but there's not many platforms out there that can really master data ingestion and CRM. So let's talk about it. Number one is real-time data access. What does that mean? Real-time data access means that whether it's your billing data through claims, your 837Is, your 837Ps, or your remittance data like 835s, or what I call payer data. What are the payers telling you? That could be external audit letters that you're receiving, DRG downgrades, all of that data. Again, claims, remits, ADRs, all of that data has to be received by a platform, ingested, and made consumable to you because it's such a wealth of information, but ingested daily and made consumable real time. A platform should not be giving you insights a week later or a month later. It is daily telling you, we're taking in your data and we're looking at it, we're interrogating it. So it's the first thing is got to be real time, got to be looking at data and ingesting data daily. The second part of that is taking that data and running sophisticated risk detection analytics. So that's going to be a wealth of things. as I talked about before, benchmarking. How do your billing patterns and denial patterns compared to CMS? Other organizations just like you. AI built in there as well. It's running constantly over that data and pointing out billing anomalies, areas that could cause you to undercode, overcode, and everything in between. Now, part of that risk detection is the third part. It's going to throw out alerts to you. So if you think about it, there's so many different things going on and being monitored by so many different folks. Again, we talked about RAC, MAC, TPE, SMRC, your commercial payers. So what you need is the ability to log on to a platform and see a real-time, think of it as a cockpit or a dashboard saying, here are your major alerts. Not only here are your major alerts, but this is the order that you should tackle those in. So again, it's looking at data daily. It's running sophisticated analytics and AI over it, providing you with a cockpit of alerts that you need to investigate. And because you're saving so much time through the CRM, then it's going to allow you that once you see those insights, you can rectify them and apply education and corrective action going forward, so those risky patterns are mitigated going forward. So all three of this may seem simple when we talk about it and we have a narrative for it, but there's very few platforms that can really, one, master data ingestion on a daily basis and provide you continuous risk monitoring on that data. So again, we'll be sending out this deck, but this is something, if you're looking at any vendor that's going to try to help you mitigate risk and maximize revenue, you should really press them on. Do you have these three things going on? And actually ask them to show it to you. And that's what we're going to do at the end. We're going to give you a nice demonstration on what CRM looks like and how you can navigate it to make your life easier and really monitor those risks, those financial risks in real time. I want to go over some more 2024 payment trends. So we talked about it a few slides ago at a very high level, but I want to dig in a little bit more. And these are four things that I'm going to kind of go through a little slower because these are the nuggets I want you to take home and say, is this happening in my data? In very most likely it will be. So the first trend is the average dollars denied per claim is continuing to increase in 2024. So let's stop and think about that. A lot of folks will come and say, oh, my first pass pay rate has improved. Or let's think of it the other way. My denial rate has improved a little bit. Okay, that's good. But when you consider that the average dollars per denied claim has gone up, you're kind of standing in the same place than you were before, or maybe taking a step backwards. So you want to make sure that you really tease out the average dollars denied per claim. Because we see in the MDaudit community that's continuing to increase. So let's talk a little bit more granular. So 62% of that on the inpatient side is being driven by Medicare. So again, last year was the flip-flop. Commercial payers really burning us. But this year, that increase very much due on the inpatient side due to Medicare. And commercial payer-related denials are increasing 4% on the outpatient side. So again, you'll be getting this deck, but you're going to want to say, am I seeing such a big increase on the inpatient side for Medicare? Most likely you are. On the inpatient side, outpatient, 4% increase from the MDaudit community for the commercial payers. The second one that I don't think, unless you're really digging into it, it may fall off the radar because folks get so busy with different tasks. But the average lag days to claim submissions continues to increase. So when we talk about lag days, that's the initial response from your payers. Now, that doesn't mean adjudication. That means they've received it and they're starting that scrutinizing period. So one of the most alarming things we've seen here, as you can see, Medicare's initial response times have increased anywhere between 5 to 10 days across all claims, pro fee, hospital inpatient, and hospital outpatient. We all know that the payers benefit from holding on to those claims and not adjudicating right away. It's money in the bank for them. So you want to pay attention. Are we seeing the same pattern with our response times? And one other thing that we talked about before is Medicare Advantage plans, 25% more initial denials in the first half of this year than last year. So on top of looking at, is Medicare really taking much longer than before with responding, you also want to, again, really delve into those Medicare Advantage plan denials. The third piece that we want to talk about is initial denial rates. So the initial denial rates across hospital inpatient and outpatient segments are still greater than 20%. Again, this is what's showing in the MDaudit community. This is crippling in some cases because it's inpatient and outpatient hospital. That's where the pure dollars are, those long lengths of stay. Patients that have many comorbidities, very acute patient mix. A lot of resources and time and money being put towards those patients to get them better and well, but then recognize over a 20% denial rate. Now, this is what I want you to go home and add to your audit plan, is what you see below that. What are they targeting? Well, some of the major DRGs that are being targeted in the MDaudit community are septicemia, infectious diseases with MCCs, ECMOs, and anything to do with the heart with MCCs. And something that the OIG just added to their work plan is that those septicemia DRGs that are being targeted, they just identified that sepsis cases with events over 96 hours had billions of dollars in overpayments when they did a study. So you can bet your bottom line that they are going to be sending you a lot of RFIs, ADRs, and denying a ton of those sepsis claims with events over 96 hours. So again, that's on the inpatient side, that first layer here. The second layer is, the outpatient. What are they targeting? What services are they targeting? Well, it's observation, care, 2-midnight rule, anything that's an implant. We see a ton of neurostimulators, pacemakers really being denied, radiology, metabolic panels, and ED visits. So again, if you take anything away from this, add some of that to your prospective audits, take a look at, am I being denied for these services? They are being highly scrutinized and denied quite often, as we're seeing in the MDaudit community. Now, this one here we talked about earlier, about dollars at risk from the external payer audits have doubled. And that's a conservative estimate. Now, commercial payers and the RACs are driving most of those RFIs. But the scarier part of this is they're coming on a prepayment basis. So if you think about it, you're submitting those claims, then you're getting an external audit on a prepayment basis. It's a lot of work and resources on your end trying to deal with these RFIs and getting these external auditors what they're looking for. And it's also leading to a rise in denials. So again, we're going to show you here how you can combat a lot of this, but we want you to be aware of these trends, because if they're happening in the MDaudit community, where we have such a kind of national footprint, it's going to be happening in your data as well. Where I want to go now is into a demonstration. But before we do that, I want to go back to this slide. What I'm about to show you, and I hope you kind of stay along for the ride, is what does a very premier continuous risk monitoring platform do, and how does it do it? Because I think you're getting a lot of folks probably coming in and saying, hey, we can do this, we can do that. But you don't really see it. You hear a lot of words, fancy words, acronyms, this and that. What I want to do is kind of boil that down to what does it look like? So I'm going to navigate a little bit and describe what continuous risk monitoring looks like. So the first place I'm going to go here is into some insights. Now, again, you're seeing the MDaudit Enterprise platform. And you're not going to see any PHI today. not going to be exposing any PHI. But a lot of what you're going to see today is trends we're seeing in the MD audit community. So I'm going to drill down to a couple of things we talked about. If you just give me a quick second. So here we go. We talked about denied amounts. Always want to be tracking what your denied amounts look like on the inpatient side, the outpatient side, and the pro fee side. So today I'm going to take a look at inpatient just because we know that massive amount of cost associated with these patient types on the inpatient side. So continuous risk monitoring, you're seeing it every month. The platform can ingest your data and kind of on a daily basis, not on a monthly, but a daily basis can put together these spikes and lulls for you. Now, just immediately, I'm seeing that we're starting to see a spike right here. So I now know I've got a bad month in denials. But the first thing a lot of you folks say, well, is I want to drill down and understand the root cause. Where do I start? So if I drill down on that bad month, the first thing a lot of you have asked me is, can you get down to facility? I have many tax ID numbers. I have facilities across the country or across the region. Well, let's see what facility is being dinged the most. And right away, it'll line up my facilities. And I'm going to want to start here at this facility. So now I know I've got a big inpatient denial issue. It's originating the most at this facility. Then I may want to drill down and say, well, what payer? What's the payer? And it could be one, it could be many. And of course, you're all going to have large payer mixes. You're going to be sending claims out to a lot of payers, but I'm going to want to start right here. So now I know it's a denial issue on the inpatient side. It is at that facility, and it is at this payer. Now I can drill down to other attributes, like what are the reasons? What are the reasons why I'm being denied? And this one here is telling me it's a duplicate service. So, but it could tell me anything. It could go back and tell me that it was credentialing. It could tell me that it was a coding issue. More importantly, then I'm able to get down to something like, what's the account number? Is that $125,000 one account number? Is it many? And it's going to percolate and say one account number. I can go in and solve that right away. It's gotten me to root cause. So again, very easy. You want a platform that can, as we said, consume the data on a daily basis, make it consumable for you so you can just go in and drill down and figure out this is the question I have and have the technology answer it for you. So another thing we talked about was average lag days. I want to know when my payers are taking longer to adjudicate my claims. Now I can see very quickly what that looks like. I don't like this, but I kind of like that. But now I'm again seeing an upward spike. From this month to this month, it's taking my payers significantly longer, 11% to really just interact with those claims that I've sent them. So I am going to actually click these 2 points. And what I'm going to do is run a change analysis. Another word for that is I'm going to ask AI to tell me why that has gone up so much month over month. What's causing that 11% spike? And when I run that analysis, AI is going to jump in, look at all of that billing and remittance data, and give me some really important things like what facility? And I can see it's this facility. And I can see that this is the payer that's causing that. Now, it's going from 10.52 to 10.9, but it's still a significant increase when they're holding on to those claims even a little bit longer. So again, I know the facility. I know the payer type. I know the payer name as well. So I'm seeing all of these things that are causing an issue here that's reducing my incoming cash. I now know where to go. Is it one account number? Is it 100 account numbers? And it's going to get me that information. And I can see there's a bunch, but this is the one account number I really need to concentrate on. I can see, did it have a certain DRG associated with it? It did. So again, I can look at this and say, my increase in who's holding on to my claims longer is this payer. I want my payer relations team to talk to them, make a phone call and say, you're against our service agreement. You're holding on to claims longer. And they're going to say, well, what account number? I need you to prove that to me. Oh, it's this account number. And it seems like you're holding on to these DRG claims longer. Are you looking for documentation? What are you looking for so you'll adjudicate these claims faster? I need the cash. So again, the theory here is, if we really kind of peel back the onion, is if you have these type of analytics in front of you, you're in the driver's seat. you're applying the same AI and analytics that the payers are. They're hoping you don't have this in front of you. So you're just kind of spending the entire afternoon a week trying to figure out root cause. If you have this, you're in really good shape. Another thing people ask me a lot about is CMI. It's kind of like, uh, how do I watch my CMI and what does it mean? And how does it hurt my cash flow? So one of the dashboards here I wanted to show you, and again, you're not going to see any PHI, but here's a dashboard for hospital CMI over the last 36 months. This is going to represent all insurances. You always need to be tracking this. And again, everything I'm doing and showing you is being done on a daily basis. So it's very easy for me to see with CMI. I'm going to have my spikes. I'm going to have my lulls, and that's normal. If I kind of draw a line across here, normalcy. We're going to see it go up. We're going to see it go down. But you don't want to be caught when it's down here months later, because that's going to affect that cash flow. So what I'm going to do is click on this. And again, I'm going to drill down. What's causing that CMI to drop so much? I need to find out the facility. Let's break it down to facility again. Which one of my facilities is bringing that down? And I can kind of go across here and immediately see it's this facility. The next thing I might want to go in and do is say, what DRGs by name? Let's just look at DRG by name. And I can see I've got a lot of ones here that I'm doing very high CMI, causing a very high case mix index as I kind of hover across these. But then I'm going to see stuff down here, and I think if we go over here, let's look at this one: aftercare without CCs or MCCs, bone diseases without MCCs, cellulitis without MCCs. So I'm not saying that these are inappropriate or they weren't sent out appropriately. But this gives someone an opportunity to go in and say, maybe some of these cases, let me take a sample size. Maybe some of these, indeed, these patients did have CCs and MCCs, and they weren't coded to the highest level of accuracy and integrity. It's a great treasure trove to go in and say, let me take a look at some of these. And again, if you go and see that the documentation supports higher levels of specificity, these can be rebuilt if you recognize it quick enough, and you can recognize that additional reimbursement. So again, the only way to be able to do that is, again, to see the tracking real time. And that's what we mean by CRM for RCM. A lot of vendors out there are not able to give you this daily ingestion and immediate insights. Okay, let's talk about another thing that a lot of folks ask me about. We are going to go into what we call facility metrics. So one of the things you're all dealing with is your PEPR reports. So I'm going to go here and we are going to take a look at a PEPR metric. Now, before I go through what this metric means, we have the ability to look at the PEPR report, look at your billing on a daily basis, run analytics over it, and give you what I mentioned before, alerts. We talked about it. Any good CRM platform will give you real-time alerts. So let's take a look at this, this card right here. I want you to concentrate right here. PEPR metric, surgical DRGs with CCs and MCCs. Well, right away, we talked about how surgical volume is going up. That's great. But CCs and MCCs, we want to monitor this for you because a lot of those CCs and MCCs, again, these are very acute patients. You're throwing a ton of resources, a ton of cost at these patients to make them well. So you want to be reimbursed appropriately, and you want to make sure you're not losing revenue, and you also want to make sure you're not overbilling CCs and MCCs. So what we have the ability to do here is say, look, you've been billing surgical DRGs with CCs and MCCs about 65% of the time. We can look at that historically. Let's just say that 65% is 24 months worth of continuous data. But over a rolling 12-month average, you've taken a dip down to 63%. Now, a lot of folks will say that's not a big dip, but it's something to certainly look at because when you're dealing with surgical cases with CCs and MCCs, even a small dip can cause major revenue leakage. But for me, the bigger number here is the benchmark. You can see we can compare your organization who's doing 63% to others just like you. You want to know, how do I compare to my peers, other organizations of similar size and constitution, similar payer mix, similar region? What do I look like? Well, that's telling you they're only doing that 55% of the time. So in this case, it's an alert. It's alerting you real time to say, take a look at those CCs and MCCs. You want to make sure you're not overbilling those or overcoding them, or you just want to make sure you're representing them appropriately. One of the nice things that any CRM platform will do is what we talked about, not only give you the alert, but allow you to dive in and take corrective action. So I want to go in right now and see, why are we doing so much more than others just like me? I want to take a look at those cases. So I'm going to go and explore that metric. And right away, in one click, I have some really important information at my fingertips, like what months in red are the months that I look like I was overbilling that. I know right away in the red. I also am going to want to know what DRGs are being billed out with those CCs and MCCs. A lot of 481s. Also going to know what payers. In this case, it looks like one payer I was billing all of those to. Attending providers on those cases. This will help me essentially choose the sample size I want to go in and audit this. Now, the nicest part of this is down here is all of the claims data that makes up that metric card and remittance data. I can go in and look at my high dollar charges. I'm probably going to go and look at my $0 payments. I can look at whatever I want, but once I tell the system, I need you to give me this right at my fingertips, I can create an audit. This backs me into a workflow where I'm able to go in and say, I'm looking at surgical DRGs. I work with the HIM department, and I'm going to assign that to Dana. Once I hit continue and create audit, that will send it to Dana's work queue, or that billing compliance analyst, or that revenue cycle analyst, whoever needs it to go in and figure out, why are we seeing this alert? Why are we doing so much more than others just like me? Now, that's where I may be overbilling it. But let's look at these just really quickly. One-day surgical DRGs with CCs and MCCs. Again, I'm doing it 9% of the time. My organization, 9%. I've gone down to 8%. Others doing it 13%. This is where I may be losing revenue. I want to go in and say, maybe there could have been higher specificity. I could have reaped more benefit, more reimbursement, more cash. So again, very easy to kind of just look at this, but what you're seeing here is CRM in action, interrogating your inpatient data and telling you this is what you need to concentrate on. You have enough on your plate concentrating on the OIG work plan. Let a good CRM vendor tell you what else to concentrate on. And again, at the end of the day, if you have this CRM and these alerts, you will mitigate compliance risk of overbilling and underbilling, and you will definitely reap more revenue. Let's go somewhere else. I know you're kind of taking in a lot today, but we just want to show you the breadth of what MDaudit can do and what a high-end CRM platform can do. A lot of folks know, we all know, whether it's pro fee or hospital, where does the big bucks come in for reimbursement? It's the procedures. Not maligning or mitigating the importance of E&Ms in the reimbursement that can bring in, but let's really look at procedures. That's really where the dollars are located. So any good platform should also be able to distinguish between your E&Ms and non-E&Ms, your procedures. So any vendor will give you a host of dashboards. Any good vendor would give you a host of dashboards. Let's look at this one, procedure units by CPT. Very easy for me to go in and see my procedures that are being billed out. But right away, I can come here to this one and say, okay, doing a lot of that J code, or whatever procedure it may be. I want to drill down and see the rendering provider group. What specialty is really cranking those out? Now, it's a good thing that I can see right here that it is internal medicine. But what I can also figure out from here is, why are these specialties doing so little? Now, that may be appropriate, but I can also compare these specialties to budget and say they're under budget. They were supposed to be doing a lot more of that procedure. Therefore, we're not recognizing the cash we expected. And when this is shown to you on a daily basis, that's where you can go in and talk to those departments. Look at their billing. Is billing getting out on time? Fix that issue at the core. Also important to be able to go see what you're doing in certain departments. So you can see what's anesthesia doing, what's derm doing, what are my hospitalists doing? And I'm able to go in there again and see, wow, we're cranking out a lot of my hospitalists are doing a great job. Let me go down and see by rendering provider name of those hospitalists or of those emergency med docs, whoever it is that you're diving into. It's then very easy to go in and see, oh, it's really one provider that's doing all of that work. What about the other hospitalists? Why are they not billing that code out as well? Or is this provider inappropriately billing out that code? It gives you a lot of immediate insights to start diving in more. One thing we should all be looking at is procedure volume by what we call RBCS family. Very easy to come in as a billing compliance analyst, or in my old days, I used to work as a billing manager. I could very easily come in and see things like colonoscopies. And wow, one of these providers is doing a ton of colonoscopies. But what about this doc? Only 8 colonoscopies done compared to 425. What's going on here? This provider's not meeting the budget that we put in place. So a lot of good metrics to really sniff out where things may not be meeting budget that you had budgeted many months before and trying to figure out why. And this is a great way to be able to glean that information. Always, always pay attention to your procedures related to what you budgeted. That's where you can really identify revenue leakage and get to root cause. So I also want to go a couple of other places before we stop and have questions. I can see a ton of questions coming in already. I want to show another quick way to identify risk. Now, I'm not going to ignore the E&M side of things because I know you're all very focused on that as well. So I am going to run what we have here is an E&M outliers bubble chart. And what we have the ability to do at MDaudit is take any provider that's billing E&Ms and we can strewn them across this continuum. And what we want to do is remove this middle because there's no risk in the middle. These are providers that are coding appropriately. We want to expose down here habitual undercoding, loss of revenue. We also want to show you up here habitual overcoding, where those clawbacks and ADRs and RFIs and all of that stuff are coming from. So you can be aware of it as fast, just as fast, if not faster than the payers. So what we can allow you to do is come in and say, how do my providers compare to what CMS considers normal E&M leveling patterns by specialty? You can also come in and compare them to MDaudit. And when you compare your providers to MDaudit, you can even get as granular as certain payers, processing region. I'm going to use CMS today, but really what you're able to do is go in and say, okay, I want to really scrutinize my consults or established patients. I'm going to put an established patient. Then I'm going to put in a specialty. Let's just make it easy and put in internal medicine. And then we're going to put in, not hemonc, let's do gastro. And right away, I've cleared out the middle and I know I'm going to go into gastroenterology. I'm going to take a look at this bell curve of Dr. Smith. And I'm going to show Dr. Smith and have a nice corrective action and education session saying, hey, you're billing out all of these level 3s, almost 100% of your volume is going out these level 3s. You're doing no level 4s or 5s. Also show Dr. Smith that his peers have a much more steady pattern of level 3s, 4s, and 5s. It's really showing that he's highly overbilling those level 3s. And I can also come down here and see that's what CMS, or if you want to flip it to MDaudit, considers normal. So it's very easy to go in and say everybody else in your department, Dr. Smith, is much more in alignment with the norm. I want to go in and see why you're overcoding those level 3s. We want you to bill less of those and bill more level 4s and 5s because your documentation is darn good and you deserve that extra revenue. Again, this isn't possible unless you have a vendor that can present this to you real time. You're getting a step ahead of the payers. One thing I forgot to show you, and then we're going to end in a few minutes, is any platform that is worth its weight in gold, and this is something MDaudit is really proud of, is the ability to ask questions real time without needing to know Tableau, SQL. I don't have those skills, never had those skills. And I'm going to be asked to find stuff out immediately. Someone's going to tap me on the shoulder and say, I need you to find this out. So we offer generative AI, where you can ask questions in plain English. You can see I've asked a lot of questions here. I'm not going to type it in front of you, but I'm going to say, what facilities had the highest amount of denials last year for med necessity? We all know med necessity is a huge denial category. AI is looking at my question that I asked, and it's immediately lined up what I asked for. These are my facilities with the highest amount of medical necessity denials. Now I know this is the center, the facility I want to look at. Now I will go down and say, well, what payer was denying me for medical necessity? Okay. It's going to line up those payers for me, and I can very easily see this is my number one payer. Let's call it United. Then I can drill down and say, okay, what are the services by name or code that they're denying? And it's going to spin that information for me, look at all that remit data and tell me, wow, you got a lot, which is expected, but number one is this one. And we talked about imaging, the radiology services, very highly denied. Right there, breast imaging, issue. These are things, again, that unless the system can compile it immediately, as soon as you ask that question, you're going to be behind the payer scrutiny. Last thing I'm going to show here is we talked about external auditors really ramping up activity. We've seen the external audit activity from RACS, Max, TPE just going through the roof. So what I'm going to do is show you how the platform can help you understand how you're doing with your external audits. So let's jump in and take a look at that. So you're seeing something called benchmarks. All of you are dealing with external auditors, and you're doing your best to really fight the good fight, retain more revenue and refund less from those RFIs and those ADRs, those pesky clawbacks. But you kind of also want to know how you compare to others. How do you know you're doing a good job or not so good job? So what we offer is benchmarks for external audit activity. Our system helps you optimize your response times to external auditors, and with many different things, capabilities, AI, ESMD, many different things, but it's also showing you the benchmark, others in the MDaudit community, and you. How do you compare? And this can be so important. So if you look at it, a couple of things are financially. How do you compare? So it's very easy to come and see who's sending me these ADRs, these pesky letters. And the benchmark, the MDaudit community, most of those, about 57%, 56% coming from private payer. And you can look at your data and say, okay, that makes sense. About 80% of mine private payer and so on. You can really see, and if it's very similar, you can say, wow, I don't get a lot from the MAC. I should be probably expecting that. You can also go in and see, how am I doing for retaining? So for those private payers, the MDaudit community is retaining about 54% of their at-risk dollars. You are really banging it out and doing a much better job. 82% of your at-risk dollars from the private payer you're actually retaining them. That's great. So you're doing a great job. Let's get a little bit more granular. Private payer down here. How much is the MDaudit community refunding? So for the private payer here, 69% being refunded. You're doing 73%, so almost on target, maybe improve a little bit. But now you can go down and see, I'm going to drill down and say, okay, I had to refund, but what were the final outcomes? Why did I refund? MDaudit can look at your external audit activity and say, bunch of it was a DRG change. You decided not to appeal. Some were denied after appeal. Some were partially denied. If you ever want to jump in and say, well, what DRGs didn't we decide to appeal? I can ask that. What were the DRG values that were targeted? And I can see the number one was this one, 901. And I may even want to go in and say, well, what were my comments during that external audit process? Why did I decide not to go ahead? And you can get a lot more information through comments. You can even, again, see what facility that goes back to, the attending provider on those cases. These are ways to go in again and compare yourself to MDaudit and even dig deeper. You're also going to want to know how much you're retaining. So let's just do a side-by-side comparison. OIG, you're only retaining 9%. Same here in the MDaudit community. So how am I comparing? That's important. I think the best part of this is we'll also show audit targets, targeted DRGs, targeted HCPCS, diagnoses, and so on. I'm going to go to targeted DRGs. Now, very easy to come in. Again, the benchmark. What DRGs are being targeted in by whom? Septicemia is the number one. Same thing, septicemia. That makes sense. We know those sepsis cases with vents over 96 hours, highly scrutinized. We talked about that before. Next one here in the MDaudit community is infections and parasitic diseases with MCCs. For you, not so much. But this is where, you had it number 3. But this is where you can go in and see, wow, they're being scrutinized for cardiac valves and craniotomies. We're not. Maybe we should do an internal audit on that because I know everybody else is being targeted for that. This is where you can add it to your audit plan. And again, what's the ending? Get ahead of the payer. You know you're going to get these external audits. Put it in your audit plan. So again, a great way to go in and see exactly what the MDaudit community is being targeted for, because you know at some point you will too. So folks, that was kind of a very quick overview of what CRM looks like. It's not fancy on the surface, but what's fancy is what's going on behind it. This only can be done if a vendor is master data ingestion, has the right AI and analytics, and that can offer workflows, integrated workflows that once you want to back into the claims data and remit data to do a further investigation, you can do that. Not many vendors can do that. So again, I want you to go, I'm going to pull up this screen. Give me 1 second. Whenever you're interacting, we hope you consider MDaudit, but whenever you're interacting with someone that's saying, I can do CRM for you, put them to the test. Do they have real-time data access? Do they have sophisticated risk detection analytics that, again, that was the part where you saw give you alerts? And does it allow you to take corrective action and apply education through an integrated workflow and reporting that will show you what the next step should be, what provider is overcoding or undercoding, what coder is not giving the highest level of accuracy and integrity with their HCCs and MCCs? Any good vendor will be able to do that for you. And we hope you want to find out more about MDaudit. What I'm going to do right now is stop the demonstration. And I'm going to ask Joy, I saw a bunch of questions come through. So I'm going to ask Joy to just toss out those questions to me. And there's also a poll out there too that you can take.
Great. Thank you, Dana. Yes, I just launched the poll. Would love for you to complete that prior to leaving, but we did receive a few questions. So the first one is, how do I know if I can trust the analytics and AI?
Okay, great question. So AI and analytics is certainly happening now in the wave of the future in the healthcare industry. We at MDaudit, we call it people, process, and technology, meaning technology is there, it's very valuable, but it needs to work appropriately and in tandem with the people using it. So you folks are the true subject matter experts. The system, any vendor should be honest in telling you that Yeah, we can identify issues, but at the end of the day, you as a subject matter expert are the ones that will take that information and validate it. But that's what it is technology doesn't work on its own. And that's a good thing. It's not going to do your job in totality. It's going to tell you where there's billing patterns outside of normative ranges, and you will be able to go in and do a validation of that. And again, that's why it's so important to have a seamless integration to a workflow that says, hey, the analytic that gave you an alert for your, high risk DRGs with CCs and MCCs. Here are the cases that comprise that analytic that allows you to take a deeper dive. So it's always not technology on its own. It's people, process, and technology as a partnership.
Great. The next question is, with the RFIs you mentioned, do you see payers paying or denying once they receive what they ask for?
Yeah, so and I have that here. Let's just go back to the screen. Yeah, for the RFIs, it is almost common knowledge that payers are sending out these RFIs as kind of a tactic to just hold, if you think about it, holding cash. That if they're sending RFIs and delaying payment, the cash stays in their bank longer, gains interest, all of that economics. We're seeing that they are eventually paying. The RFIs are not resulting in a very high amount of denial. So they're still paying, but it's taking much longer. They want to put you through the ropes, have you send that information and so on, and keeping that money on their side. But they are eventually, in most cases, adjudicating and paying those claims, but putting quite a price on you. And again, that's why I say you want to pay attention. Have your payer relations team jump into that. See if there's no funky business going on with the payers going past the agreements they have with you to adjudicate claims, even if RFIs are involved. But we are seeing a lot of payments come in if you play that game.
Thanks, Dana. Next question. What is the best practice next steps once an alert is identified by CRM?
So I would say a best practice, we just kind of talked about it, so I won't go into detail, but a best practice from both a vendor side and a subject matter expert side of things is once that alert is identified, you want to be able to immediately almost have like an easy button that you can click on that alert and give you the information you need. So think about it. I'm having a lot of denials for coding. Click the easy button and know what facility, what provider, what payer, what services. But all of that, again, the best practice for that would be able to pull that into a workflow where you're not at that point asking for data from IT or trying to run reports manually, because then you just lose time. You lose time, the payer wins. So best practice would be to have not only a vendor that can give you that information at your fingertips right away, but that you can go in and interact with that data. So best practice would be, again, dig into the analytic, get to the root cause through the claims and remit data. That to me would be best practice. And never forget that if you identify a pattern, to communicate that pattern, because education and corrective action is really the key. If you can go back and say, hey, this is why we're being denied by this payer. When we send this code, they need this documentation. If you bring that to the appropriate stakeholders, even if you're encoding, let's say, you can bring that to RevCycle, Rev Integrity, HIM, break down those silos, have a lot of corrective action education, and then these patterns will mitigate going forward.
Questions. Does CRM replace claim scrubbers and claim edits?
No. So again, the claim scrubbers you have in place, they serve a purpose. Claim scrubbers are really good at looking at every field, every loop and segment that's on a claim and saying, is this populated with the right demographics, and does it have a modifier in field XYZ? You need that. It serves a purpose. But this is different. This can work in tandem and should work in tandem with your edits, your homegrown edits that you're building, an Epic or Athena, whatever it may be, Meditech, whatever it is. This is another layer on top of that. It's more of an analytical brain on top of some of that more kind of rudimentary technology. So it's not replacing it. It's working in partnership with the scrubbers. And we see many of our clients with multiple layers of claim edits, scrubbing systems, and so on, where it doesn't catch some of the things that it should be doing. A lot of that stuff that's denying for med necessity based on payer policy. This is where CRM can come in and be a really good complement to those.
Thank you, Dana. And the final question, is there anything I can do to fight payers taking longer to pay due to RFIs?
Yeah, I think the first thing is, and it's not easy, is having metrics and understanding which payers are sending those RFIs to you. It's not going to be everyone in your payer mix. It's going to be, you know, a few pesky ones here and there. So you got to identify that first. Who's sending those RFIs? And then at that point, again, you have to play that game, but also bring, as I said before, bring your payer relations team in. There may be, it's very easy to go into negotiations if you have the metrics that's saying, you know, you're constantly asking for these RFIs for this code. I've compared it to your policy, and there's nothing in your policy that says I have to do this or that. So it's really, to combat that, you have to understand who's sending it. Is their RFIs appropriate in alignment with what their adjudication policies are saying? And if not, bring in payer relations, sit at the table and have that conversation. Doesn't have to be adversarial, but it can say, hey, you as the payer are doing something that in our agreement, in our contract said you wouldn't do. And if it's appropriate, then it's just at that point, maybe building edits and saying, I know when I bill out the situation, I may get an RFI. I want to be prepared with what documentation I need to send. So I think the first part is teasing out who's sending it to you and why, and making sure that it's appropriate. So those are great questions. I know we only have a couple of minutes left. So folks, again, happy to work with you if you want to ask any other questions. You will be receiving this deck, this recording, and again, hopefully you're taking home some nuggets that you can apply to your billing compliance and revenue integrity programs. But in the end, MDaudit would love to work with you as a CRM platform, and I think there's a lot we can do for you. And thank you very much for joining the webinar today.